Hi, everyone. Dr. Hina and I are back for another episode of our video podcast. And today we will be talking about what are the ingredients of a good prescription, particularly for a family physician. So, welcome, Dr. Hina. Um, I hope your day has been well up until now.
Yes, it's been a bit busy, but yeah, life is going on.
Okay.
Mhm.
Uh, uh, so my first question about prescription writing, we all go to GPs and we are also doctors. So we know that prescription is one of the key element that bonds the patient with the doctor. So tell me something about prescription, and then what should go on a prescription from a family physician perspective.
Okay. Uh, with regards to prescription, obviously, this is something which a community-based general practitioner or a family physician or a primary care physician does on a daily basis, a number of times in a day. And because we see a variety of patients from different age groups, from younger age group to elderly, extremes of ages, we have to be very, very careful when prescribing medications. So what I would like to suggest is always stick to the ethical principles. Um, it is less likely that you will make a mistake. So we'll come in detail and talk about the ethical principles later in detail. However, before prescribing, always ask yourself a question: is a prescription needed in this case, in the clinical scenario? If the answer is a yes, then there is a number of steps you need to go through. For instance, is your patient affording? Um, are you prescribing appropriately according to the guideline? For instance, if you're prescribing antibiotic for an upper respiratory tract infection, most common infections are tonsillitis, acute pharyngitis, then is your prescribing according to the clinical guidelines? Uh, are you choosing the right antibiotic? Is your patient okay to take that antibiotic? He hasn't got any allergies to this. Have you got anything in the record already there? And can is there anything else that needs to be given to this patient in addition to antibiotic? Remember, do not put too many things on the prescription. Not more than 2 or 3 medications for an acute prescription is what is suggested. Um, it's best to stick to a format. You can always keep that format somewhere written so that you don't forget. Um, always write the date of your encounter when you've seen the patient, patient's name and address, the date of birth, your name, your address, and your registration number. Ensure you write the name of the medication clearly. In capital letters is preferred, but we
Mhm.
understand there are a number of patients you see in a day and you can be rushed at times. But if you make it a habit, it's less likely you will forget.
Mhm.
It's ideal to write generic names as opposed to brand names,
Okay.
because then it may indicate you are favoring a particular brand, and then things like conflict of interest and other issues emerge. So when you've written the name, make sure you write the strength of the medication. In what dose form? Is it oral, injectable, in the form of patches, sublingual, intramuscular, whatever is the form? And how many times in a day? What's the frequency? How to use the medication? Is it before food, after food? And how long should the medication be taken? And towards the end, make sure you put your signature and your details as mentioned earlier, like name, your address, and registration number. So in case patient needs to get in touch with you.
So thank you very much. That's really useful. So basically, you've described the basic structure of a prescription, where yeah, you write about the patient information, medication name, dosage, frequency, route of administration, and also prescriber details. so many things you have to do in such a short time. So how do you ensure the legibility of a prescription when you're writing that quickly? I mean, you have some time that you have to, spend on every patient. How do you ensure that?
Okay, as I said, it's difficult for us to remember each and everything. So it's a good idea to put things as small notes or reminders for yourself on your table or a place where you can easily see it. But if you do it on a regular basis, you will develop the habit and your brain will pick up if you're missing anything and you will become faster as well. The first few days, initial few weeks would be difficult, but once you get into the habit, you're less likely to make a mistake and you're less likely to forget.
Mhm.
And you do get that incorporated within the 10-minute consultation. And that does include wrapping up, providing a prescription, explaining anything in the prescription. It's sometimes a good idea in places like South Asia where we are based. We usually have nurses within our room setup, or their room is not very far. So if you feel you are not able to explain the prescription fully, or it needs to be explained again or in a bit more detail, you can always send your prescription and the patient to the nurse sitting nearby, and she
Mhm.
would be able to go through it with the patient. Sometimes the language is different as well. You may
Yeah.
not be able to speak patient's language, the local language. And the
Mhm.
nurses are a very good resource for that. They kind of act as a top up for whatever advice you've given.
That's a good tip to use nurses to explain to the patient what is there on prescription. So you said about ethical prescribing. What
Yes.
is ethical prescribing?
Right. Ethical prescribing is when you are incorporating the four principles of ethics, which is patient autonomy, beneficence, non-maleficence, and justice, fairness, or equity. So autonomy, is the patient wanting the medication?
Right.
Does the patient agree to taking a medication? Has the patient been given an option?
Mhm.
For instance, in general practice, there are certain conditions where doing nothing
Mhm.
is an option, which means you can wait and watch and tell the person about the red flag signs. If there are any danger signs, they come back. Um, there are other conditions, for instance, mental health problems, where you can prescribe antidepressants, but there are other options like counseling, cognitive behavior therapy. So you list all those options and ask the patient which one you prefer. Do you prefer one, more than one? And there are a number of times where patients say, no, I don't want to take an antidepressant. I'll try any other method.
Mhm.
So that's the autonomy side of it. Now, the beneficence is the medication you're prescribing has got benefits for, are you acting in patient's best interest? You're
Yeah.
not going to create, for instance, think like antibiotic resistance, or give him unnecessary side effects like Clostridium difficile, diarrhea, if you're prescribing inappropriately. So benefit to the patient, best interest of the patient must
Mhm.
be borne in mind. Do no harm. Uh, Obviously, our profession is to protect patients' interest. So make sure your action is not adding to the problem.
Okay.
Um, and that is predominantly seen in inappropriate prescribing.
Thank you, Dr. Hina. So one thing which you were just talking about was mental health and prescription. Sometimes we have to prescribe medications for people with mental health, or sometimes we have to prescribe tranquilizers for some patients. So how um, do you handle such prescriptions? Because it's always a chance that this is going to be sometime abused.
Okay. In certain conditions, for instance, mental health, yes, there are medications that have a potential of addiction. Patient can get dependent on them. But there are certain which have no addiction potential. So it's better to choose the ones which have least side effect, least interaction with other medication, and it's safe and effective as well, including cost effective. Now, we all know the medications that cause dependency. if you have to prescribe them, tell the patient that this is a short-term treatment. This is not long-term, because there are better options available than this one. And it does have the potential to cause, you can get hooked to it. So patient needs to know before they are taking it. And having a conversation at the time of prescribing or before prescribing is always beneficial, because then it gives you the provision to kind of negotiate in the next, and if the patient is demanding more, and then you can kind of control the amount of number of prescription. Control drugs are the ones, they are the stronger painkillers like tramadol, like morphine, Oramorph and stuff.
Yeah.
Ideally, controlled medication there should be one medication per prescription. You shouldn't write more than one for a control drug.
Okay.
It should be written very clearly, particularly the dosage, the instructions that go with it. And also patient must be aware of side effects, particularly when they are naive and they are using the medication for the first time. So the common side effects must be known to the patient. Because sometimes when, I'll give you an example, SSRIs, which is selective serotonin reuptake inhibitor, commonly prescribed as an antidepressant, some of them cause anxiety or palpitation in the beginning.
Yeah.
So sometimes patient, when they get fast heartbeat, they stop the medication because they're not aware it's a side effect. But if you tell them, look, in the first few days, you may feel your heart is racing a bit, but it will settle down as you continue with the dose, or you can start with a lower dose and gradually build it up. So there are ways you can deal with these issues. Yeah.
So what you're saying is that when you're prescribing, you need to also educate the patient about the dosage, about the side effects, about the safety of the medication. So all those things, they're also elements of
Good prescribing.
yeah, good prescribing. Okay. So another question which I wanted to ask is, what is the stepwise approach to prescribing? You mentioned something about stepwise approach.
Okay, and the stepped approach is, I think we touched earlier a bit, which is it's a process which is going within a physician's mind, basically during the consultation.
Right.
So the physician must be able to tell towards the end of a consultation or after discussing with the patient whether a prescription is needed. If the answer is a no, you don't need to proceed further. But if the answer is a yes, then you have to choose the appropriate medication. And for that, the physician needs to be well informed. And by well informed, I mean have a grip on the common conditions and the guidelines, what the guidelines say. For example, WHO guidelines are there for antibiotic prescribing for various communicable diseases. Then there are NICE, National Institute of Clinical Excellence guidelines, which are in global use for common non-communicable diseases like diabetes, high blood pressure, things like asthma, COPD, and there are other guidelines in addition to NICE, which can be used. Is the medication cost effective? As I said, always write generic names. Do not go for brand names. Patient can always take that prescription to the chemist and be able to buy the medication of a brand which he is able to bear the cost of, particularly for conditions when they need monthly prescriptions. Is the prescription appropriate? Whatever medication I'm writing, is it appropriate for this particular patient? Is it because it's an individualized care? Not every medication is tolerated well by a patient. For instance, metformin, a commonly used anti-diabetic medication, has loads of GI, gastrointestinal side effects, for instance, bloating, constipation, abdominal pain, and patients don't like it. So how you go about, not everybody is going to get it, but those who get it, they cannot tolerate the medication. So has this patient used this medication in the past? Did they have any side effects or were intolerant to it? Having a knowledge would help you prescribe and choose another alternative if there is an issue. Is the medication safe for this patient? Has he had any allergies to it? Has he had any side effects to it? Some anti-diabetics have caused pancreatitis. So has the patient had a reaction to it in the past? And is the medication effective? for example, in mental health conditions, sometimes we prescribe tricyclic antidepressants.
Yeah.
Sometimes we give selective serotonin, SSRIs.
Mhm.
Tricyclic is good, but according to the evidence base, SSRIs are more effective. So again, that's where the evidence base comes. If you've kept your knowledge up to date as a physician, you attend the CMEs regularly, and you keep yourself well informed, then you are able to negotiate and able to provide more options to the patient.
Thank you. So, stepped approach means to ensure the appropriateness of a prescription for a specific patient. Um, and then you also mentioned using guidelines, particular guidelines. So, what guidelines are used in Pakistan and South Asia? Are there any particular guidelines for the region, or that's used there?
Okay. So as I said, in general, for non-communicable diseases like high blood pressure, diabetes, respiratory illnesses, chronic ones, we use the NICE guidelines or the SIGN guidelines. SIGN guidelines are the Scottish Intercollegiate guidelines. WHO guidelines are used for antibiotic prescribing, and they've got they regularly produce this document, which is updated every few years. For tuberculosis, there are national guidelines, and they are again easily available from the websites, and the links can be available. They are shared commonly on our family physicians WhatsApp groups or other resources. Similarly, for dermatology conditions, again, there are various resources like patient.co.uk or this gpnotebook.com. These are some of the websites that give you ideas about prescribing for various common dermatological conditions as well. Some websites are completely free to access. You don't need to make a payment or a registration. But there are multiple resources available, which I think a practicing GP needs to be aware of. Derm NZ is another one, which is easily accessible and it's regularly updated, so you can use it for any skin-related problems too.
Thank you, Dr. Hina. I think now I'll show you one or two prescriptions that you shared with me, and we'll discuss those. And then, yeah, we will discuss those in line with what we have just discussed. So this is one prescription where we've anonymized it. So, but this is one prescription, and I would like your comments on this prescription based on your talk of good prescription writing.
Yeah, I mean, you can see there are 3 antibiotics prescribed here. The dose is given, the form is given, but it doesn't clearly, oh, it does say in Urdu, yeah, on the other side, how much to take. And it does say how many days they need to be taken. But if you look at the combination of antibiotics that have been selected, I would raise concerns about this, and I would question what's the condition that is requiring a combination of all the broad spectrum antibiotics. Has there been any culture of sensitivity done? Has the microbiology result shown any sensitivities to these antibiotics? My question would be, what if the patient doesn't respond? What if the patient condition gets worse? What is my backup then? If I'm using everything in the first place, then what as a physician is my backup? And whether this prescription is given by a qualified practitioner, is this a community-based general practitioner or a specialist? Has any input been sought from a specialist before prescribing these antibiotics? So what's the origin of this prescription in a way? What made the physician put everything on the prescription? And is any ethical principles being applied to it? That would be my concern.
So this is a tough one because we don't have any age, any demographic information of a patient, and we've just given you this medication. But thank you very much for raising the point about giving multiple antibiotics to a single patient. And we don't know whether they have done any investigation. Um, okay,
As far as
so
I
the
remember, this is a prescription of a 20-year-old hypertensive,
Mhm.
and he presented with unexplained shortness of breath for 5 months,
Okay.
and recently diagnosed with chronic kidney disease as well. So considering patient is only 20 years of age, diabetic, known diabetic, hypertensive with a chronic kidney disease, I'm assuming he may have taken a number of antibiotics in the past because of the multiple comorbidities. And it does say no known allergies to medications.
Yeah.
Uh, yeah, yeah. But
Yeah.
I'm sure there is a reason why the physician has prescribed, but then one would question.
Yeah. So thank you. And then this prescription, the legibility is a bit, so it's a bit not clear, but it's age of the patient is 5 years and the weight is 24 kilograms.
Mhm,
And on the prescription, they have given a history of unwell for 3 days, fever, headache, vomiting.
mhm,
And then on examination, uh, meningitis, they're suspecting, I think, meningitis, TLC is 25, which is raised, tender mastoid, I don't know, ENT consultation is required. On the left side, it's written, please admit in pediatrics. They've given some injections and they've given some dosage. There are two types of injection. Then they've advised fundoscopy, LP, a number of other investigations. So, what do you think about this prescription, and how do you think this could be improved?
This is obviously looks like a hospital based or maybe an OPT based and going for admission. The writing is too small. I would struggle to read it. If I'm sure the chemists who are based in the hospital or nearby places may be familiar with the writing, handwriting, and are able to pick up. But I think it's a risk we are taking. And as I said, it's best to write the name in capital letters so the margin of error is less. And but yeah, legibility is an issue here. And if you're handwriting it, that make sure it's easily readable.
Yeah, they've also said give 2 doses today, so don't know what. So that's the injectable that they've given. So
Mhm,
based on this, Dr. Hina, if you were to improve this prescription, so you're saying that one should have name in capital words. So because of anonymity, we just removed the name. So the name was in the local language, and they've given age and weight of the patient. What you're saying is that, yeah, and this is for admission because they've said that admit this patient and given
mhm,
some dosage. The handwriting is quite small. Um,
mhm.
um, and other than that, uh, this is fine.
If we go through our checklist,
Yeah.
obviously I won't be able to comment on the some of the things because we have
Yeah.
for
So
confidentiality
could be a
purposes.
repeat patient. We don't know. Yeah.
So yeah, a date. I'm sure the date must have been
Yeah.
written,
So date
and
is
as far as date is written, as far as I know, in the local language, as you said, the name of the patient was written, but it was the surname was missing.
okay.
So two patients may be of the same name, so it's
Yeah.
best to write the complete name of and also a son of or daughter of something like that, just to make sure
Um,
the, the there is less error and the medication doesn't go to the wrong patient. The date of birth wasn't mentioned, age was mentioned. So I think it would be preferred to mention date of birth rather than the age because two patients can have the same age. And a bit more detail, like in terms of demographics of the patient's address for further follow-up, any contact number of the parent would also help.
good.
Um, in terms of medication, I think the drug names there, the strength is there, the frequency, how it should be prescribed. The quantity isn't mentioned clearly, and the duration isn't mentioned very clearly here.
Yeah.
Yeah, so maybe those two things would have been.
So yeah, I mean, I think that's, you made very important points, that the If it's a child, the parents, the father or the carer name should be there, and also date of birth, because two patients can have similar names and ages, and because it's an admission patient, so we know all that a lot of mishap can happen during admission, where two patients with the same name can easily get mixed up. Um,
Yeah.
all right, so I'll just stop sharing this. Thank you very much for your detailed analysis of these two prescriptions. Anything else that you want to add to the good prescription writing, because before we finish our podcast?
Okay. Always remember that there are two sources for, rather resources for good prescribing, which I think, how can we share these? These are two links. Anyway, I'll share them with you, and perhaps we can attach them with this recording, so people can benefit from those resources for good prescribing. But the take-home point would be, as a prescribing physician, it's your responsibility to keep well informed. As I said, ensure checks, make sure you're safety netting, make sure you are informing patient about the common side effects and what to look for. For instance, when we are prescribing a combined oral contraceptive for the first time to a patient, and they never experience migraine headache, so you tell the patient, if you experience a one-sided or a generalized headache, which is a new onset, then report back to us, let us know, and stop the medication as soon as you can. And ensure your prescribing practices are not influenced by various factors, like pharmaceuticals, and you do avoid getting into activities like promotion of a certain brand, as I said, and because remember, that will lower your prescribing quality, and that is something you do not wish to compromise. So that is
So
what I
what
would
do you
like to
do
say.
when, so sometimes patients come to you, and I'm talking about my own experience when patient comes to you and you look at the patient and you think that that patient doesn't need any medication right now, which you've already mentioned, and then you don't give them any medication, or just give, for instance, any anti-inflammatory for the time being, or so how do you negotiate with the patient? Because a lot of patient, when they come to the doctor, they have this expectations that we are going to go to the doctor and they're going to prescribe us antibiotics if they have any fever or something. How do you negotiate with the patient? Because I used to find it very difficult.
Yeah. Yeah. I think that's where the evidence base comes. And obviously the experience, the number of years you've been working. So the evidence base gives you the confidence, and your consultation. You've by that time, before you get to the point of prescribing, you've collected the data, you've examined the patient, so you've got a working diagnosis in your hand, and and you're only able to give the options if you have a good backing of evidence base. Tell the patient that the larger studies have mentioned this, this, and this. I do not have any problem prescribing. It's easier for me to prescribe, but it's difficult for me to not prescribe and explain and educate you. I can give you information leaflets about the condition. I can give you a delayed prescription, which means you take the medication from me today. However, you do not start the medication for another 24, 48 hours. See how your condition is. If it's improving, you don't. If it doesn't, then you do. So there are ways to negotiate, and patients do understand. If you take the pain and explain it to them, they can see that as well, that you're taking that concern and you're showing that concern. Yeah.
Yeah, that's good to know, Dr. Hina. I mean, of course, it comes with experience, but in countries like Pakistan and in countries, other South Asian countries, where we have pharmacies which are quite strong and which prescribe medication. I mean, even if you don't prescribe any antibiotic or something, and then they go to a pharmacy and the pharmacy prescribes them. Do you think that there are any measures that a family physician can take which can, stop this practice? Because we have a region where we have quite high antimicrobial resistance.
Sure. I think good patient education by a qualified trained primary care physician, is the best answer. Once you educate the patient, and yes, when you tell patients, if you use the antibiotic inappropriately, you will end up contributing to the antimicrobial resistance, and then it will be harder to treat you. And patients do understand, and I understand what you mean. It's at the end of a day, it's patient's autonomy. He or she may wish to walk out of your room and then go and find a chemist and get an antibiotic. That's another story.
Yeah.
But as long as they are making an informed decision,
Yeah.
you have done your job, you have informed them. Now,
Yeah.
whatever they want to do, it will be their responsibility. So you have to hold the patient responsible as well. And you can only hold them responsible once you have informed them fully.
Thank you very much, Dr. Hina. Lovely talking to you as always. And I think our viewers and our listeners will learn a lot from this video podcast. And hopefully we'll talk again in future. Thank you very
Inshallah.
much with a new topic. Thank you.